Mhm. Can you guys see my screen?
Yeah.
Great. Okay, let's get started. So the way it's going to work is we'll go through a long case, we'll take a history, see what examinations come up, do some SBAs, and that's it. So this is your first scenario. So Bobby is a 15-month-old boy and he presents with a sore ankle. And the pediatrician is concerned because he has bruises all over his body, including his torso. So if everyone can log on to Menti and type in what are the causes of bruising in patients. So not necessarily in this patient, but what are some of the causes of bruising in all patients? Yeah, great. So we've got DIC, trauma, abuse, very important in a child especially because that raises safeguarding, thrombocytopenia, um, von Willebrand, yeah, medication, yeah, hemophilia, yeah, great. So the way you can divide it is there's kind of two main medical causes of bruising. One is the platelet disorders, and the other one is the clotting disorders. So the platelet disorders is basically when there's low platelets, so thrombocytopenia. And thrombocytopenia is either caused by a reduction in platelet production or an increase in platelet destruction. So some of the reasons for reduced platelet production is the viruses, so EBV, CMV, HIV, B12 or folic acid deficiency, liver failure, myeloid dysplastic syndrome, and chemotherapy. Whereas increased platelet destruction is your ITP, TCP, HIT, HUS, alcohol, sodium valproate, methotrexate. And then the clotting disorders is got to do with disorders within the clotting cascade itself. And those are the inherited ones are von Willebrand disease, hemophilia A and hemophilia B. And then we've got DIC, which is a mixture of both clotting and platelet disorder. You can't, I don't think it's classified as, it's kind of both. Um, and that's disseminated intravascular coagulation, and then of course trauma. So if this 15-month-old boy presents with a sore ankle, bruises all over his body, and you're asked to take a focus history, what kind of questions are you going to be asking? So remember, this is a focus history, so like really think about what questions you're going to ask. Yeah, really good. So just, for the people joining now, we're thinking about a 15-month-old baby that's come in and he's got bruises all over his body and he's got a sore ankle. And if you're asked to take a focus history, what kind of things will you be asking in this scenario? So everyone just like log into Menti, please. Um, yeah, family history of heme conditions. When did it start? Mechanism, diet, yeah. Trauma, okay. Frequency of bleeds, deep, superficial, great. Hemoarthrosis, very good. When did it start? Okay, fever, all of that. Sudden weight loss. Has this happened before? How often? Yeah, so we've got some really good responses here. So let's see. So any focus history. So focus history came up in our OSCE last year, and essentially within a 10-minute station, 5 minutes you'll be asked to do a focus history. And I think nearly all of the stations we were asked to do a focus history. So you have to be really concise and effective in what you want to ask. So obviously there's a structure, but for each condition or each presenting complaint, there's specific questions that you must ask. So in your presenting complaint, you need to identify. So once someone tells you what the presenting complaint is, you need to then start thinking of all the differential diagnosis, and then prioritize the most life-threatening ones first. So always have a differential, even if the diagnosis is obvious. So if when someone presents with, I don't know, headache, if you're asking questions and it's obviously a migraine, what they're describing is a migraine, that doesn't mean you don't ask the other questions, such as stroke symptoms, subarachnoid hemorrhage symptoms, cluster headache, GCA symptoms. Like, you still need to ask all of the potential causes of that symptoms. You still need to ask all of those questions. So that's what a focus history is really about. Don't rule anything out at that stage. And then history of presenting complaint. This is when you ask a bit more specific questions to rule in and out your top differentials. Again, you always want to start off by talking about the most life-threatening ones first. And then any history you want to ask about red flag symptoms such as weight loss, night sweats, fevers, signs of infection. In pediatrics, any like safety netting, any trauma, all of that. And I would say you want to ice the person early on. Because then you won't have time at the end. So just ice them at the beginning, and then systems review, keep it very brief. Don't go on and on about this. And yeah. So in a bruising history, you would ask site of bleeding and bruising. When does it occur? So does it happen spontaneously or after trauma? If you have a bruise after trauma, that's pretty common. If you have a big bruise relative to a very small mechanism of injury, that's a bit of a problem. So if I just, I don't know, fall from standing and I have a really, really massive hematoma, then there's something wrong, right? As opposed to having just a small bruise, which would be in proportion to how I fell. And then bruising spontaneously is a red flag. You shouldn't be spontaneously bruising for no reason. So if someone comes in saying, yeah, I've noticed bruising, I didn't fall, I didn't have any trauma, that's red flag. A red flag for cancer, that is. So again, the size of the bruises, are they small, small and superficial, or are they large and deep? So large and deep bruises are more likely to be a coagulation factor or clotting factor deficiency, whereas a small bruising is more likely to be von Willebrand disease. Have they had any previous bruising or bleeding? Any bleeding from the gums, the skin, any nosebleeds, any I can never say this word, I'm not going to try again. Any PR bleeding, vaginal bleeding, and these are all mucosal bleeding. So any bleeding from a mucosal site, you need to ask about that. And if it is a history of mucosal bleed, then it's more likely to be a platelet disorder. Or von Willebrand disease. Then we've got hemarthrosis, which is bleeding into the joint or bleeding into the muscle, and that's more seen in hemophilia. Any bleeding after surgery or trauma, is it mild and immediate? That's more likely to be von Willebrand disease. And platelet disorders and heavy and delayed bleeding is more likely to be clotting factor disorder. So in general, if it's more lighter bleeding, it's more likely to be a platelet disorder, unless there's hemophilia, in which we'll get onto that later. And if it's more heavy and deep, more heavy and delayed, then it's more likely to be a clotting factor disorder. Have they had any headaches or trauma to the head? So elderly people that have had a fall and they're on blood thinners can get a intracranial bleed quite easily. Menorrhagia, so obviously in our patient, it's not relevant, but if a woman came in, you would want to ask duration of her period, how many heavy days she's having, any clots, any flooding, are they still able to go to school and go to work? Past medical history, any history of blood cancers, bleeding disorders, liver failure, drug history, again, all the blood thinners, warfarin, heparin, any antiplatelet medication, family history. Von Willebrand disease is quite common in families because it's autosomal or dominant. So you will often you will see it in multiple generations. Hemophilia A and B. So hemophilia A and B have a specific inheritance pattern, which we'll go on to later. So that's really important to ask family history there. Any bleeding disorders in the family, any history of cancer in the family, and then social history is risk factors such as smoking, alcohol, recreational drugs, occupation, living situation, do they have help at home, and of course, safeguarding in children. And then systems review, any like headache, dizziness, changes in vision, stuff like that. But you would obviously go through all of the systems quite quickly. Like you would ask about the neuro symptoms, you would ask about chest symptoms, bowel symptoms, bladder symptoms, joint symptoms, and that's pretty much your systems review. So once you've done the history, this is what you learn. There is no prior past medical history, and there's no medication that the baby's on. This is the mum's first child. She's only 19 and has just moved in with her new boyfriend. They are conducting a safeguarding review, but also want to check that there are no underlying bleeding disorders. The patient, so the baby, is refusing to weight bear. His left ankle is warm and swollen. He has numerous large bruises all over his body, and there is no family history of bleeding disorder. The mum does suffer from menorrhagia, and the baby's hemoglobin is 117. And then his prothrombin time is normal, but his APTT is prolonged, and the 50-50 mix fully corrects. So this is your first SBA. So what do you think the next best step in management of this patient is? Let's go back to the question. Give you another like another 30 seconds. Yeah, so I'm seeing some questions in the chat about 50-50 mix. I'll talk about that later. Essentially what 50-50 a 50-50 mix that fully corrects means that it's not an autoimmune problem, which we'll talk about later. So that's all I can tell you at this stage. How does alcohol cause platelet destruction? Is more in that the alcohol messes up your liver, and that can affect your platelets. But otherwise, I'm not really sure how directly alcohol messes up your platelets. I would think it's got to do with the liver, but I'm not entirely sure on that. Okay, let's see what everyone said. Okay, so the majority of people have said check factor 8, 9, and von Willebrand factor. Okay. Yeah, great. So that is true. So in this patient, you're suspecting for an inherited bleeding disorder. So factor 8 and factor 9 are the factors that are deficient in hemophilia. So you're checking for hemophilia with those two. And von Willebrand factor is the factor in von Willebrand disease. So you're checking for that disease with that. Factor 12 has nothing to do with this. And tell the pediatrician that this is likely an incidental lupus anticoagulant and not to worry. Again, if the 50-50 mix fully corrects, it can't be a lupus anticoagulant because this is not an autoimmune condition. So you can rule the other two out. And we'll talk about 50-50 mixes later. So a bit about hemostasis. I'm no expert in this, but to like make it really simple, there's primary hemostasis, which is where you form a temporary platelet plug. And this is to seal like small blood vessel injuries. And the formation of this platelet plug is using von Willebrand's factor which then sticks to the vascular injury. Then that factor binds to GP1B receptors on the surrounding platelets. After binding, the ADP receptor on the platelet is activated, and that leads to increased expression of GP2B and 3A. And those newly expressed receptors then finally bind to fibrinogen, which then leads to further platelet aggregation. So primary hemostasis is forming the platelet plug. And just remember that von Willebrand factor is essential in that. The other stuff, you don't really need to know it in depth. Like, this is not pre-clin, but then, if you want to be knowledgeable, learn it. Secondary hemostasis is the clotting cascade. So this is where it's the stabilization of the platelet plug that you made before in primary hemostasis. And you stabilize the platelet plug by forming a fibrin mesh through the clotting cascade. So there's two pathways of the clotting cascade. There's the intrinsic pathway and the extrinsic pathway. Intrinsic is triggered by damage to the blood vessel, whereas extrinsic is triggered by tissue damage outside the blood vessel, so i.e. from surrounding tissues. And then both pathways come together to lead to the activation of factor 10, which then starts the final steps of clotting, and you finally form a clot to stop the bleeding. So yeah. Again, do you need to remember all of the factors and the entirety of the clotting cascade? I personally don't think you need to learn it for the exam. Now, again, for your own knowledge, you should probably learn it. So yeah, so the way to differentiate, so this is a rule, but there are some exceptions to this, which I'll point out later. So there's the clotting disorders, and then there's the platelet disorders. The platelet disorders have prolonged bleeding after trauma, surgery, mucosal bleeding from the gums and the nose, petechiae, which is small red spots, easy bruising, and menorrhagia. The clotting disorders have all of those symptoms, plus they have the more intense bleed, such as hemarthrosis, bleeding into the joints, muscle hematomas, internal bleeding, and large, deep bruises, such as hematomas. So the more severe ones tend to be a clotting disorder. So understanding the clotting tests. So these are the common tests that you will see in your exam questions. You'll see prothrombin time, INR. You'll see APTT, and you'll see bleeding time. So PT and INR measure your extrinsic pathway, and the factors involved are factor 7, and it can be affected by anticoagulation use, liver failure, DIC, and conditions associated with that would be vitamin K deficiency, liver disease, and DIC. It can also be used for warfarin, to monitor warfarin. Out of these 3 bleeding tests, this is the least relevant, or like you're least likely to be tested on this one. APTT is really important because APTT assesses your intrinsic pathway, which is factor 8, 9, and 11, and von Willebrand factor. So APTT basically tells you about your hemophilias and your von Willebrand disease. So if you see APTT looking a bit unusual, you need to think, these are my inherited platelet disorders. Yeah. So, and then again, it can be affected by anticoagulation use, liver failure, DIC, but most likely that when they bring up APTT, it's in the context of hemophilia and von Willebrand disease. Bleeding time assesses how quickly your platelet plug is formed. Again, it's affected by your platelet disorders. It's affected sorry, it's affected by your platelet disorders. It can also affect von Willebrand disease, TTP, ITP, HUS, and thrombocytopenia. So yeah, so just I would say the main takeaway here is know your APTT is used for your hemophilia and your von Willebrand disease. The 50-50 test is when they take a patient's blood sample and they take a control sample. So what that means is you have your patient sample and then you have another sample which has the normal level of clotting factors. So if you have your patient's sample and the clotting and there's a clotting and you think there's a suspected clotting factor deficiency, if you mix the control sample, which has a normal level of clotting factors, into the patient sample, then the sample should become normal, right? The patient samples should correct, and the patient's blood should now have the normal amount of clotting factors because you've just added it in via the control sample. If you add the control sample into the patient sample and the patient's clotting factors do not go up, that means there's something in the patient's blood that's blocking or interfering with the clotting factors that we've added. And that's something that could be interfering with the clotting is something like an antibody. So they could have an autoimmune cause, and rather than a deficiency. So rather than a true deficiency, i.e., they're not making enough, there's something that's blocking the stuff that's being made. So that's you would go more down the autoimmune route. So that's what 50-50 um 50-50 mixing means. I hope that makes sense. Um, next. So here's your next SPA. A 17-year-old girl presents to her GP with a history of mucosal bleeding. She had an episode of prolonged bleeding after a tooth extraction a few weeks ago and has had heavy periods since menarche. She's otherwise fit and well. A coagulation screen demonstrates a prolonged APTT and a normal PT. An FBC demonstrates a hemoglobin of 100, so it's low, and a platelet count of 200. Given the likely diagnosis, what is the most appropriate management? So I'll give you guys a minute to answer that. Someone will ask, what is HUS? HUS is hemolytic uremic syndrome, which you'll also learn about in renal. And it's basically, what is it? It's low platelets, thrombocytopenia, anemia, and an AKI. I'm pretty sure that's what that is. But you'll go over that in renal as well. But yeah, so if you see uh platelet problem plus someone's got an AKI, it's most likely to be HUS. Okay, let's see what people have said. So some people have said tranexamic acid, and some people are saying recombinant factor. Interesting. Um, okay, someone said factor 8. Okay, okay. So the correct answer is desmopressin. So this is a young girl. She's got mucosal bleeding. She's had heavy periods. She's got bleeding after tooth extraction, so that's gum bleeding, which is another mucosal surface. Heavy periods is bleeding from a mucosal surface again. So history of mucosal bleeding that's been established. Her APTT is prolonged. So remember, if it's a prolonged APTT, is either going to be one hemophilia or von Willebrand. Her PT is normal. Um, she is anemic, and her platelets are normal. So because she's got prolonged APTTs, either hemophilia or it's von Willebrand. It's unlikely to be hemophilia because hemophilia presents with hemarthrosis and hematomas. And hemophilia is also an X-linked recessive condition that affects males more. So this is more likely to be von Willebrand because of the history of mucosal bleeding plus prolonged APTT is a classic situation of von Willebrand disease. And the first line is desmopressin. You can give tranexamic acid in primary care if her only problem was menorrhagia, you can give tranexamic acid. But she's got bleeding after a tooth extraction, for which you would give first line desmopressin. So that's the correct answer. I hope that makes sense. So yeah, von Willebrand disease. So signs and symptoms is bleeding from mucosal surfaces. So that's nosebleed, um, heavy periods, uh, mucocutaneous bleeding, bruising in the absence of trauma. Causes is an autosomal dominant autosomal dominant, meaning that men and women, you'll see it equally in both. And usually there's a couple generations of it. So if you take a family history, someone in their family probably has it as well. And there's three different types. So one is there's a partial reduction in the factor. Two is there's an abnormal form of the factor. And type three is that there's a total lack of the factor. And that is inherited through the autosomal recessive way. And it's the most severe one. Um, they mostly assess you on type 1 or type 2. So the autosomal dominant one is the one that they assess you on, which is the one that you hear about the most. Again, clinical findings, you'll see a prolonged bleeding time and a prolonged APTT time. And you can also see a reduction in factor 8 levels as well. Treatment is desmopressin, uh, factor 8 infusion, von Willebrand factor infusion, tranexamic acid for mild bleeding or menorrhagia first line. You can use combined oral contraceptive pill for menorrhagia as well, or mefenamic acid, marine coil, all of those things. But if someone's having a bleed after von Willebrand, you would most likely use desmopressin. Okay, here's our second SBA. A 3-year-old boy presents to the emergency department with a grossly swollen, stiff, and painful left elbow after falling accidentally, knocking it against a table. A clotting screen is performed, which demonstrates an elevated APTT and a normal prothrombin time. His platelet count is also normal. Given the likely diagnosis, which of the following clotting abnormalities is likely to be present? Someone asked where will you find the slides? So the slides will be uploaded to the Google Drive, which you get access to if you become a MedSoc member. See what everybody said. Okay, interesting. So people have said factor 8 deficiency or factor 9 deficiency. So the correct answer is A, factor 8 deficiency. So I think most of you have got that this is hemophilia, because he's got that hemarthrosis. Again, elevated APTT. And what can an elevated APTT mean is either hemophilia or von Willebrand. It's definitely not anything platelet related because the platelet's normal. Um, so this is hemophilia. Uh, Hemophilia A is factor 8, and hemophilia B is factor 9. So it's either going to be the answer will either be A or B. The reason why it's A is hemophilia A is just more common than hemophilia B. That's literally it. So, but yeah, good on you guys for identifying that it's hemophilia. So hemophilia, there's two types. There's A and B. Hemophilia A is factor 8. I remember it because A sounds like 8, and then B is just one more, so it's 9. Inheritance, they are X-linked recessive. So women are carriers, and most likely a man will be affected. But sometimes women can be affected. So if a man is affected, doesn't comp if it's a woman, you can't rule out the fact it's not going to be hemophilia because they can get affected. It's just a lot more rare because of the X-linked recessive inheritance. Again, blood test, prolonged APTT with a normal bleeding time and normal prothrombin time. Signs and symptoms, joint and soft tissue bleeding, excessive bleeding from minor trauma, hemarthrosis. So hemarthrosis is very characteristic in hemophilia. Um, hemarthrosis is kind of easy to remember. So you can get joint deformity, compartment syndrome. Again, you also have mucosal bleeding. So it's similar to von Willebrand, except on top of the mucosal bleeding, you get these muscle and joint bleedings, and it's an X-linked recessive disorder. The treatment, you basically just give them the factor which they're lacking. So if it's hemophilia A, you would treat with factor 8. If it's hemophilia B, you give them IV factor 9. So it's quite explanatory, the treatment. There's an acquired, this is very niche. I doubt they'll ask you this, but there is an acquired hemophilia A, which is rare, and that's when you have an acquired inhibitor of factor 8. So instead of being deficient in factor 8, so i.e. your body's not making enough factor 8, you have something that's there that's inhibiting your factor 8. Hence why it does not correct on 50-50 mix. I hope that makes sense. So again, you have the APTT will be prolonged, but the 50-50 mix will not correct because you've got that inhibitor there. Same kind of symptoms, soft tissue, so causes soft tissue, skin, mucosal organ bleeding, but less frequent joint involvement. Again, you just treat the bleeding. In this case, because it's a you need to you need to do immunosuppression because they have that inhibitor, and try and abolish the inhibitor so that whatever antibody or whatever they have needs to be dealt with. But yeah, this is niche, so don't worry about it too much. Your next SBA. A 43-year-old patient presents to the hospital feeling generally unwell. For the last 3 months, he has noticed weight loss and a reduced appetite. More recently, he has had blood in his urine, easy bruising, and oozing from his gums whenever he brushes his teeth. In the past few days, he has noticed a few digits on his lower limb go cold and turn dusky. His blood tests are shown below. Hemoglobin of 72, platelet of 36, blood film shows schistocytes presence, INR 4.5, and APTT of 100. What is the most likely diagnosis? Be a few more seconds on that. Okay, interesting. Some people have gone for thrombotic thrombocytopenic purpura. Some people think it's immune thrombocytopenic purpura, and some people think it's DIC. Um, if you are getting questions wrong or you feel like these questions are hard, heme is hard. Like it's okay. Like heme is hard. Heme is hard because everything kind of looks and sounds the same. So if you're when you're revising heme, um, just recognize the pattern of the different conditions and know what differentiates one from the other. That would be my biggest tips, especially the ones where it's like ends in a P, like the ITP, TTP, all the Ps. Just keep in mind what is the pattern in each one, because that will help you. And once you know the pattern, the questions become a bit easier to understand. So the correct answer is DIC. The reason is he's got weight loss and a reduced appetite. So he's got some sort of cancer. He's got bruising and oozing from his gum. So he's got uh, bleeding and mucosal bleeding. He's got low platelets and he's got schistocytes present and his APTT is prolonged. His INR is also prolonged and he's got anemia. So with DIC, it's important to note what things can cause DIC. Things that I can remember are cancer. Cancer is a big one, and sepsis is a big one. That can cause DIC. The APTT will be prolonged. It can cause low platelets. And then schistocytes on blood film is characteristic of DIC. It's schistocytes don't appear in everything. So DIC is one of those conditions where they definitely do appear in. So if you see that word, think DIC. Von Willebrand disease. I mean, I know I told you guys that the APTT is prolonged. It could be either hemophilia or von Willebrand disease. I'm going to add another thing to that statement. If only the APTT is prolonged, then it's hemophilia or von Willebrand disease. This guy has too many things going on. He's got anemia, he's got low platelets, he's got schistocytes. So it's not that. Thrombotic thrombocytopenic purpura and ITP we'll talk about later as to why it's not that one. Hemophilia, again, he's got too many things wrong with him for it to be hemophilia. And then DIC is the answer here. So DIC is a combination of abnormal bleeding and abnormal clotting. So it's those two things happening kind of at the same time, where you've got someone bleeding and someone clotting at the same time. So the way that happens is you get abnormal activation of the tissue factor, which then triggers excessive clotting, which then depletes the platelets and then clotting factors through the intrinsic and extrinsic pathway leading to bleeding. So what happens is your platelets are basically being told to do more and more. So the platelets then cause the clotting. But because your platelets are busy clotting away, you then run out of platelets and then that causes bleeding. That's how I like to think of it. So it causes sepsis, trauma, malignancy, obstetric causes, amniotic fluid embolism, vascular abnormalities, severe liver failure, and toxin. So mainly sepsis, trauma, and malignancy are the main causes. And the clinical findings will be thrombocytopenia, reduced fibrinogen, increased prothrombin time, increased APTT and bleeding time, increased fibrinogen due to increased fibrinogen degradation products, and schistocytes due to microangiopathic hemolytic anemia. So if you see schistocytes, the two things that cause schistocytes is microangiopathic hemolytic anemia or DIC. And in DIC, you get this microangiopathic hemolytic anemia. So it's DI. So hence why you get the schistocyte. So in why is it, it's not letting me go back? So in TTP and ITP, you won't be seeing schistocytes. So if you see schistocytes, think DIC. In TTP and ITP, you'll be seeing other things. In ITP in particular, it will be usually an isolated reduction in platelets. So the only thing that will be wrong with him really is that the fact that the platelets are low. And then TTP we'll talk about later. So yeah, just remember schistocytes is DIC. Your next SBA, a 75-year-old woman attends the hematology clinic after having blood tests performed by her GP that show thrombocytopenia. She's clinically well and currently asymptomatic. Physical examination shows no abnormalities. Her latest blood results are shown below. Which of the following is the next best step in the management of this patient? Let me know if I'm going too fast or things are not making sense. Just shout it out. Okay, let's see what everyone put down. Interesting. There's such a big split. Okay. Two of you said observe. Some people said plasma exchange. Someone said oral prednisolone. Someone said mycophenolate, um, mofetil. Interesting. Um, okay. The correct answer is oral prednisolone, because this is immune thrombocytopenic purpura, also known as idiopathic. So the main thing here is if it's an isolated thrombocytopenia, meaning everything else is normal. So if you go through her test results, first of all, clinically she's fine. She's not having any symptoms. She's got this thrombocytopenia. Two, her hemoglobin is normal, white cell count normal, platelets normal, APTT normal, prothrombin time normal. So everything is normal. So just an isolated thrombocytopenia, in a woman especially, is likely to be ITP. And because it's an immune mediated thing, or thought to be an autoimmune thing, you would give oral prednisolone. So that's the answer here. Yeah, so that's the right answer. So immune/idiopathic thrombocytopenic purpura, it presents in both adults and in children. So what it is it's a condition where the immune system attacks and reduces your platelets. Antibodies target proteins on the platelet surface, such as the glycoprotein 2B and 2A, or 1B5 and 9. So your body's just attacking your platelets. So your platelets go down. And that's the only problem you should be having. in terms of your blood tests. The signs and symptoms in adults is it can be discovered incidentally, so hence the lady had no symptoms. Um, so it's you could be normal and then it just shows up. Or it can have petechiae or purpura, as in the name. So you can present with those rashes. You can obviously have any bleeding, but catastrophic bleeding is not like a common presentation. In kids, it's more acute than in adults and may follow an infection or vaccination. So if you see a kid coming in after an infection or a vaccination, and the only problem the kid has is that his platelets are low, it's likely to be ITP. Again, in kids, you can get bruising, purpuric rash, petechiae, and bleeding is less common and typically presents as nosebleeds or gum bleeding. Investigations, FBC shows an isolated thrombocytopenia. So if you think ITP, the I in your head should be isolated and the T should be thrombocytopenic. That's how you remember it. And then you can also do a blood film. I don't know if I don't think it shows anything specific to ITP, but management in adults, first line for ITP is oral prednisolone. Makes sense because this is an autoimmune problem, so give it steroid. You can also give IVIG if that doesn't work. In kids, most cases require no treatment and they resolve within 6 months, but you want to avoid activities with trauma, team sport, and you can give platelets if their platelet count is very low or give steroids or IVIG. But usually 80% of cases resolve within 6 months in kids. So here's your next SVA. A 32-year-old female presents to A&E following a seizure. She is post-ictal and unable to give a history. On examination, she has a low-grade fever and has multiple purpura across her body. There is no evidence of meningism. Her blood tests show the following. Her creatinine is raised, but no baseline is available. A blood film reveals schistocytes. Her PT and APTT, fibrinogen, and D-dimers are all within normal range. What is this definitive treatment for this presentation? Few more seconds. Okay, let's check. Okay, so some people said splenectomy, someone said rituximab, and two people said plasma exchange. Interesting. Let's see. Yeah, so the correct answer is plasma exchange. So again, this is a classic example of TTP, thrombotic thrombocytopenic purpura. And so there's usually a pentad of symptoms in TTP that you should just memorize, which is AKI, neurological features, microangiopathic hemolytic anemia, hence why she's got the schistocytes on blood film. So if you see schistocytes on blood film, like I was saying, it's caused by microangiopathic hemolytic anemia. And the two things that you get is DIC and TTP. You then also have low platelets and you can have a fever as well. So this is a pentad of symptoms that you will see. So this woman has had neurological features. She's just had a seizure. She's got a low-grade fever. She's got multiple purpura all across her body. Her hemoglobin is low, so she's got some type of anemia. And it could be microangiopathic hemolytic anemia. But the point is she's got anemia, so that's ticked. Her platelets are low, and her creatinine is raised. And if your creatinine is raised, is most likely caused by an AKI, right? Um, and yeah, and her platelets are low, and of course the schistocytes showing the microangiopathic hemolytic anemia, and her PT, APTT, fibrinogen, and D dimers are all within normal range. I think a question similar to this came up um, in our exams last year, and one of the difficulties for me is differentiating between TTP and DIC. But in DIC, you will simply have less symptoms. If it's a pentad of things, like I said, like if and in DIC, you might not see like an AKI, and you might see and DIC, you might see a clear sepsis picture or a clear malignancy picture causing that DIC. But in this case, she's not got any of that. She's got a neurological thing that's motivating this. And then she's got all the symptoms of the pentad. So I would say really make an effort to learn the difference between TTP and DIC, because in the exam, I was scratching my head thinking, which one is it? So get to grips with that, because I think they're like asking questions that differentiate the two. And the treatment for TTP is a plasma exchange. Yeah, someone asked, why is this not DIC? Could this be um, sepsis causing what did they say? They say could this be an infection causing DIC because of the fever? That's a great question. But in it could be in real life, it could be. But in exam world, if it's a classic pentad of symptoms, right? It's most likely not to be DIC. In DIC, I don't think you'll see the renal problem. I don't think you'll see an AKI. I think that's what the difference is. Is this one most likely will present with an AKI, and it'll be so subtle, like a creatinine has gone wrong or something like that. You're like it's that one where it's a hematological it's a DIC picture plus something's not right with the kidneys. If you see a DIC picture in the stem and the kidneys are not fitting with the DIC, or the kidneys are looking weird, it's most likely to be TTP, and that's how I would describe it. Now, I don't know if that's the right way of doing it. But if you're answering exams and you're finding it difficult, I would say look out for the AKI and look out for the neurological features, because neurological features won't be causing DIC. So remember the pentad and remember that DIC doesn't present with AKI usually. Okay, so the classic presentation of TTP is a female patient with autoimmune disease, and she's got prolonged bleeding and thrombocytopenia. So you'll see features such as thrombocytopenia, microangiopathic hemolytic anemia, thrombosis, so the formation of blood clots. Um, and also the reason why she's got the kidney problem in the first place is because the thrombosis is damaging the kidneys, hence why she's got an AKI. And you also see renal failure. So this is a DIC, sorry, a TTP picture. The causes are it's an autoimmune disease, and it's where you have antibodies to ADAMTS13 deficiency. Um, you can get acquired TTP, such as in SLE, in pregnancy, post-infection, if you're on the pill, if you're on certain medication, such as cyclosporin, penicillin, clopidogrel, acyclovir, oral contraceptive pill, and then HIV. So look out for those things in the stem as well. Pathophysiology, sorry, the pathophysiology is the deficiency of the ADMTS13 causes uncut von Willebrand multimers, which then cause small blood vessel blockage, which then causes platelet depletion and low platelet count. The testing, you would do FBC blood film for schistocytes, you would do user needs for AKI and clotting studies, and the treatment first line is oral prednisolone. If that doesn't work, then you would do plasma exchange, and then you can do rituximab. But if it's a first line treatment, it's oral prednisolone. Sorry, first line is not oral prednisolone, it's plasma exchange. I said that wrong. Um, Yeah, sorry. Because the question here is definitive treatment. The definitive treatment is plasma exchange, but your first line treatment could be prednisolone. But so you need to read the question as well. So definitive treatment would be plasma exchange. Hope that makes sense. And then you've got heparin-induced thrombocytopenia. This one is relatively easy. So that just is heparin induced antibodies targeting platelet factor 4 on platelets, which causes thrombocytopenia. Um, and you can suspect HIT in any patient on heparin with thrombosis or low platelets. And to solve it, just stop using the heparin and use a different anticoagulant. So that's pretty self-explanatory. Um, So I want to ask, is TTP a heme emergency? Because if there's malignancy or sepsis causing DIC, be more of a heme. I think they're both heme emergencies, to be fair. If you see someone with well, DIC is definitely an emergency. If you see DIC, that's not good. Um, Whereas TTP, I think the difference is if you see DIC, DIC is more common and you're more likely to encounter it, I suppose. Whereas if it's a TTP picture, you would, I'm guessing the hematologist would take over and deal with it entirely themselves. Whereas because DIC comes in sepsis and you could be in acute med dealing with someone with sepsis and then they can get DIC, you have to diagnose that yourself more likely. Do you get what I mean? Whereas TTP is a bit more niche and a bit more heme, whereas DIC is involved in anything. But yeah, I would say they're both not good. Okay, now we're going to move on to heme cancers. Um, yeah, yeah. I know the bleeding shit was difficult. I get it. Just practice, learn the difference between all of the platelet disorders and the clotting disorders. And once you recognize the patterns, you guys will be fine. And all your questions will be correct. So, sorry, all your answers will be correct. So don't worry about it. You've got loads of time. Um, and just keep doing the questions, man. Like that's the only way. Um, so now we've got heme cancers. So there's the leukemias that which are high yield. You need to know all of the leukemias. There's the myelomas. Sorry, there's only like one myeloma. There's multiple myeloma. That's the main one, and that's high yield. And then we've got the lymphomas, which are also high yield, but the non-Hodgkin's lymphoma especially is quite high yield. So know your heme cancers. Um, okay, so I made a cheat sheet. So we'll go to that. I made a cheat sheet for leukemia. How do I exit this? Um, okay, cool. What was that? Okay. So I made a cheat sheet for leukemia because if I made this into slides, so the whole point of the leukemias are like with the platelet disorders, the leukemia is also kind of similar in which they sound the same, but they have their own individual things that make them different. So I made it into a table so it can be easier for revision, and we'll go through that now. If I made this into slides, this would be another 100 slides, which I don't want to make or go through. So let's get started. And you can access this if you just copy and paste a link um, from the slides. So there's 4 types. There's AML, CML, ALL, and CLL. AML is acute myeloid leukemia. CML is chronic myeloid leukemia. ALL is acute lymphoblastic leukemia, and CLL is chronic lymphoblastic leukemia. So the pathophysiology. So if you have a acute leukemia, whether it be AML or ALL, because it's acute, is more likely to be the expansion or proliferation of immature cells. So if you see immature cells, like blasts, then it's more likely to be AML or ALL. If you see more, differentiated cells, or no immature cells, or mostly mature cells, then it's more likely to be a chronic leukemia because they've had time to mature. And so the cells that will be proliferating are the well differentiated and the more mature cells. So AML, acute myeloid leukemia, is the expansion of immature blast cells. CML is proliferation of granulocytes. ALL is proliferation of lymphoid precursor cells, again, like immature cells. And then CLL is proliferation of well-differentiated lymphocytes. Yeah. So the ALL and CLL originate from the lymphoblast line, and then AML and CML come from the myeloid line. It's in the name. And then lymphoblastic leukemia. So lymphoblasts are like your T cells and your B cells, and then your um, myeloid cells then differentiate into a bunch of different things, like basically everything else. So that's another way to differentiate them. So the causes of AML is translocation between 15 and 17, and the fusion, the chromosome 15 and 17, and the fusion of PML and RAR alpha genes. This is characteristic of AML, so just memorize any chromosome thingy, just memorize that because it's unique to that cancer. So AML is 15 and 17. CML is the Philadelphia chromosome. The way people remember it is CML, CM is cream cheese, and Philadelphia is a cream cheese brand. So that's one way to remember it. It's the Philadelphia chromosome, which is a translocation between chromosome 9 and 22. You'll also see BCR ABL gene, which causes excess tyrosine kinase activity. There's no specific causes for ALL or CLL, or like a characteristics one that I found that could help you in exams. The epidemiology is also very, very important. So younger adults is AML is younger adults, CML is older adults, ALL is in children. So if you see leukemia in a child, most likely to be ALL. Because all children are cute. That's how I remember it. And then in kids, it's more likely to be boys than girls. And then CLL is the opposite, in which if it's an old man, more likely to be CLL. CLL happens quite often in older men. So that's that. Symptoms and signs. AML has frequent infections, mouth blisters, leg bruises, menorrhagia, gingival hyperplasia. CML in the exam questions, you will see splenomegaly, massive hepatosplenomegaly, bone pain, easy bruising, bleeding, neurological deficits, visual problems. In ALL, you can see B symptoms such as weight loss, fevers, all of that. Ecchymosis, petechiae, frequent infections, lymphadenopathy, hepatomegaly, splenomegaly, and testicular swelling. And then in CLL, you'll see something called the Richter transformation, which I'll talk about more in detail. But the Richter transformation in the leukemia cells, Richter transformation is when your leukemia cells enter the lymph node and change to diffuse large B cell lymphoma. Whatever that means. But if you hear of a Richter transformation in the stem, it's CLL. Acute B symptoms, abdominal pain, lymph node swelling, that's CLL. I think when you see a leukemia question, it's important in the stem to look at any of the causes. So any specific mention of any chromosome or gene thingies, and also look at who it is. So look at the epidemiology and look at the specific signs and symptoms. If it's splenomegaly, it could lead you more towards CML. Richter transformation, it's CLL. Blood tests. So in the bloods, you will see in AML anemia, thrombocytopenia, neutropenia, and myeloblasts. Makes sense because it's a myeloblastic leukemia. So you will see myeloblasts. In CML, you can see anemia, but you'll see granulocytes at different stages of maturation. So this is kind of sorry. So the difference between CML and ALL in a blood test, you will see more you will see more mature cells in your chronic myeloid leukemia because you've got more time to mature if it's a chronic thing. Whereas in a acute myeloid leukemia, you're mostly seeing blast cells, which are the immature form, so the myeloblasts. And acute leukemias can cause pancytopenia and blast cells with no mature cells. That bit should actually be in the AML section, sorry. But if you see in any acute leukemia, basically the blasts multiply so much that you get all the other cells get suppressed, so you get pancytopenia, and there's no mature cells because they haven't had time to mature. ALL, again, anemia, thrombocytopenia, neutropenia, lymphoblasts. And again, you'll see lymphoblasts. So in AML, you'll see myeloblasts. In ALL, you'll see lymphoblasts. I'm repeating this for the millionth time. Remember, it's the blast cells. If it's acute, think blast cells. CLL, you will see lymphocytosis of mature lymphocytes, again, because it's a chronic leukemia, thrombocytopenia, anemia, immunoglobulins. So just remember whether you're going to see blast cells, whether you're going to see mature cells, whether it's a myeloid cell or lymphoid cell, and then boom, you know which one it is. Investigations. So sometimes in chronic myeloid leukemia, you can get a blast transformation where suddenly you'll be in the chronic phase. You have chronic myeloid leukemia, and then suddenly you get it can turn into AML. So the chronic myeloid leukemia can quickly become acute myeloid leukemia, and that's very bad. And you don't want that happening. So if someone's got chronic myeloid leukemia, the last thing you want them to do is then go into the acute myeloid leukemia phase, because that's when all the immature cells are proliferating and all the other cells get suppressed and you get pancytopenia. So that's your worst nightmare. So you can determine that by seeing the percentage of blast cells in your peripheral bone marrow or your blood. The diagnostic factor is Philadelphia chromosome in CML. In ALL, you would do bone marrow biopsy. You'll see hypercellular heavily packed with lymphoblasts. You can do positive path staining, flow cytometry. In CLL, Richter transformation, you probably see that. You can do lymph node biopsy, and the most important investigation is immunotyping for antibody type, because that's linked with your Richter transformation where it does something to the B cell. So you have to deal with the antibody type. Histology, again, very important. If they give you histology in a stem, you're really lucky because then you can immediately tell which one it is. If it's AML, it comes with our rods. So you see that little rod there. I don't know if you can see my cursor, but you can see like a rod inside of the cell, and that's our rods, and that's classical of AML. CML is just myeloblasts, mature myeloid cells, and multiple basophils. So you will see a variety of cells. In ALL, you'll see very large lymphoblasts with prominent nuclei, and in CLL, you'll see smudge cells. So it looks like it looks like the cell has been like squashed and smeared almost. So those are your smudge cells. So remember those. Poor prognostic factors in AML if you're over 60 or if your blast cell is more than 20%, which is not good. And if your blast cell is more than 20% after your first chemotherapy, that's a poor prognostic factor. In ALL, if you're aged under 2 or over 10, that's bad. If your white blood cell's more than 100 and you're anemic, if you have uh, uh, T or B cell surface markers and a Philadelphia chromosome, if you're non-Caucasian, male, B cell predominant, that's also bad. More than the poor prognostic factors, the thing that they will ask you is good prognostic factors in this case. And the only one with a good prognostic factor is in ALL if they have hyperdiploid blast cells. So remember that as well. And then there's associated conditions with some of them. With AML, myelofibrosis is common, polycythemia, essential thrombocytopenia, myelodysplastic syndrome, and any condition with a JAK2 mutation is also important. So memorize those. In ALL, it's in kids. I don't know why in kids, I don't know, for some reason, Down syndrome just is more memorable. And so is neurofibromatosis. Warm autoimmune hemolytic anemia is the one for CLL. And that's that. So I know this is a lot of info, but like really try and remember this. And just remember like the mutations, epidemiology, signs and symptoms, and um, the histology, and it's not that bad. So now let's do some SBAs. I'm tired already. Um, where were we? Mm, Okay. Okay, so this is our leukemia SBAs. So I hope everyone understood that, or like if that was like an overwhelming amount of information, I'm sorry, but it has to be done. Like you need that information. But yeah, take your time learning it. Just keep doing the questions and you'll be fine. So back to our SBA. A 53-year-old female presents to the GP with a 6-week history of malaise and a 3 kg weight loss. She also reports early satiety and abdominal discomfort. There is no past medical history of note and no recent travel history. On the physical examination, there is a palpable mass arising from the left upper quadrant and extending to the right iliac fossa. The mass moves with respiration and has a dull percussion note. Which of the following investigation findings is most consistent with the most likely diagnosis? Okay, a few more seconds. Okay, let's see what people have said. So people have gone for peripheral blood shows mature myeloid cells and multiple basophils. And someone also said peripheral blood film shows leukemic blast cells. Interesting. So I'm glad everyone thought this was a leukemia. The correct answer is E. So let's go through things one by one. So A, showing a blood smear showing smear cells or smudge cells would be CLL. And I don't think this is CLL because it's not an old man. It's a middle-aged woman, so it's unlikely. Um, it's and there's no Richter transformation. Thick blood smear showing Plasmodium falciparum is malaria, and that's got nothing to do with this because there's no fever, travel, anything like that. C, peripheral blood film shows leukemic blast cells. So I think the between C and E, so C is AML and E is CML. This person has massive splenomegaly. It's extending all the way from the left iliac fossa, sorry, from the left upper quadrant into the right iliac fossa. That's massive. So massive splenomegaly is always CML. And well, if you a massive splenomegaly should point you towards CML, but the thing that confirms that this is CML is the fact that is is sorry, the thing that would that's more likely to be CML is the massive splenomegaly. And if it's a CML, you're more likely to see mature myeloid cell because it's a chronic leukemia. So the difference between chronic and acute will show you blast cells, which are the immature cells, whereas the chronic will show you mature cells, which are the mature myeloid cells, essentially, because you have more time to mature. So that's why it's E and not C. D is, I think, for hemolytic anemia, so that's irrelevant to here as well. So it's either between C and E, massive splenomegaly, usually CML. Yeah. And also it's a leukemia because she's got weight loss, satiety, abdominal discomfort, malaise, all of that. If it is a chronic leukemia, why is there no smear cells? So if it's a chronic lymphoblastic leukemia, then there will be smear. So chronic lymphoblastic leukemia is a smear slash smudge cells. That's the only one where you'll see a smear or smudge cell. That's CLL. CML, you won't see that. CML, you'll see massive. So CML, the M stands for massive splenomegaly. Just remember that. Whereas CLL, you can see the smudge. You'll see the smear cell. That's what that's for. Okay, next SBA. A 30-year-old male presents with fatigue and bruising. Bone marrow biopsy shows the presence of a large number of abnormal promyelocytes, so neutrophil precursors, but very few mature neutrophils. Cytogenetics reveals a T1517 translocation. Given the findings, which of the following is the most likely diagnosis? I think this one is a bit more straightforward, so let's see what people put. Okay, someone said ALL, someone said AML. So 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 there's two groups of leukemias, right? There's the AML, CML, and the ALL, CLL. Um, the myeloid leukemias, which is AML and CML, will have myeloid cells, such as you'll see words like myelocyte, neutrophil, but they'll specify that it's a myeloid cell type. If it's a lymphoblastic leukemia, such as ALL or CLL, then you will see a lymphocyte cell type. So you will see a lymphoblast or lymphocyte or T cell or B cell. So in this stem, it says promyelocyte. Because they're saying myelocyte slash neutrophil precursors, it's a myeloid leukemia. So we can cross out the lymphoblastic leukemias, right? So it's not ALL, it's not CLL. So that leaves us with AML and CML. Because it says it's abnormal, there's numbers of abnormal promyelocytes, meaning the immature myelocytes, and there's very few mature neutrophils. These are immature cells. So immature cells happen in the acute leukemias. So you're more thinking it's more likely to be AML. And then your final thing is that it's got a 1517 translocation, which is characteristic of AML. So that's just a fact that you would need to remember. So the answer here is AML, and that's not why it's ALL, because ALL is it's a lymphoblastic leukemia, and these are not lymphoblast cells. These are not T cells, these are not B cells, these are not lymphocytes. So we can rule that out. And ALL will also, remember, is in kids. So you will not see that in a 30-year-old male. And ALL also does not have a 1517 translocation. I hope that makes sense. So yeah, when you're thinking leukemia, first think, is it a lymphoblastic or is it myeloid cell? So differentiate the two. Is it mature cells or immature cells? So is it if it's immature, acute, mature, chronic, and then look at other bits and bobs of information that hit the nail in that this is this specific type of leukemia. I hope that makes sense. Um, yeah. Um, yeah. Okay. Um, so next SBA, a 70-year-old male patient presents to the GP for annual review of his diabetes. He's asymptomatic at present and his diabetes is well controlled. The GP orders some routine blood tests and the white cell count is found to be 12.8. So it's high with 85% lymphocytes. Which of the following blood film findings is consistent with the most likely diagnosis? So yeah, just keep that framework in your mind. Is this lymphoblastic or is this a lymphocyte problem or a myeloid problem? Are the cells mature or are they immature? And then look for other pieces of information, such as age, any chromosomal translocations, and see if you can answer it based on that. Let's see what everybody put down. Okay, so people have been saying smart cells. This is good. Good. Yeah, so the answer is smudge cells. So going through our formula, is this a lymphocyte or is this a myeloid problem? This is a lymphocyte problem. So it's either ALL or CLL. It's a 70-year-old man, so it's not going to be ALL because that's for kids. CLL is characteristically in old men, so CLL. And it's 85% lymphocytes and not lymphoblasts. So lymphocyte is the mature cell, so it's more likely to be chronic lymphoblastic leukemia. If this was a lymphoblast, if there were mostly lymphoblastic cells in a kid, then it would more likely be ALL. So that's why this is CLL. And CLL, you'll be seeing smudge cells. So yeah. Okay, which of the following may undergo a Richter transformation? I hope like these SPAs aren't like repetitive and boring, but rather like trying to get you guys to try and differentiate between the different types of leukemias because I think these marks are relatively easier to get than the DIC, TTP, and all those things. Those are a bit more complicated, but the leukemia questions, it's kind of easier to get full marks because it's very straightforward once you remember what thing is what. Okay, let's see what people put down. I'm sorry if I'm going quick, but like, I'm conscious of time. People said C, okay. Oh my God, you guys are so smart. Exactly. See, now I think people are getting it now. So smudge cells, so we're kind of going backwards. So C is if you see smudge cells, it's in CLL, and CLL is the one where they undergo Richter transformation. Cool. Which of the following is most likely to have massive splenomegaly? Okay, let's see what people put. Um, so some people think it's A, some people think it's B. Yeah, so the answer is B. So B is CML because it's got all the different types of cells, not just blast cells. Um, and the way you would know this is CML is because the other three are so distinctive that you would know once you've like before exam season and you've done all your revision, you would know these three are quite characteristics of their specific leukemias, and the last one kind of left over is CML. So the answer is B. Which of the following is likely to have an FBC that will show immature myeloblasts and no mature cells? Let's see what people are putting. People said A. Well done. Yeah, so our rods is AML. And of course, AML is immature myeloblasts and no mature cells. Great. Which is the most likely to happen in kids? Let's see what people are putting. People are saying D. Yeah, so D. So ALL is big lymphoblast cells. So yeah, well done, guys. Okay, cool. Next, a 12-year-old girl presents to the GP with a sore throat. She has been feeling tired and run down recently and has noticed her gums bleed excessively when she brushes her teeth. Her mum has also noticed that she has a lot of bruises on her legs and arms that she can't explain. On examination, she looks pale with a temperature of 37.2 and a heart rate of 100. Her throat is red and inflamed. There is cervical and inguinal lymphadenopathy and hepatosplenomegaly. On abdominal examination, you notice multiple petechiae on her legs. Given the most likely diagnosis, which of the following is a good prognostic factor? The people are saying hyperdiploid cells. Yeah. Exactly. So if you see, this is ALL. It's a young kid. She's got a leukemia. She's got young kid leukemia. She's got leukemia because she's got hepatosplenomegaly. She's got bruising, bleeding. Leukemia in a young kid is ALL, and in ALL, the good prognostic factor is hyperdiploid blast cells. So just remember that. Yeah, but well done for people that remembered. Okay, a 25-year-old man has presented to his GP after noticing a lump in his neck a few days ago. He's not sure how long they've been there. It is not currently painful, but he reports it becomes painful when he went out for some alcoholic drinks with his friends last Saturday. He has no other symptoms. On examination, a 2 centimeter rubbery, non-tender lymph node is noted in the right anterior cervical chain. There is no evidence of any other lymphadenopathy. Which of the following is the most likely diagnosis? Okay, let's see what people are putting. Okay, people are saying non-Hodgkin's or Hodgkin's. Cool. So yeah, so the answer here is Hodgkin's lymphoma. The characteristic, so one of the SBA symptoms is that if if you have a lump or lymphadenopathy that gets painful when you drink alcohol, it's Hodgkin's lymphoma. It's that simple. Non-Hodgkin's, no, because it's if you have painful lymphadenopathy after drinking alcohol, it's Hodgkin's lymphoma. Metastatic lymph nodes, no, because he's a relatively young man and he's not got any other lymphadenopathy or any other symptoms for to diagnose a primary tumor. D-infectious mono, no, because that would present a bit differently with fever. Reactive lymphadenopathy, no. The classical sign of Hodgkin's lymphoma in the exam is the lump gets painful if you drink alcohol. So that's yeah, so this is Hodgkin's lymphoma. So yeah, we're done with the leukemias and now we're going on to the lymphomas. Um, and then once we're done with the lymphomas, we have one condition left and then we're finished. Yeah, I acknowledge it's been a long time. Hodgkin's lymphoma. So this is the malignant proliferation of lymphocytes characterized by the presence of the Reed-Sternberg cell. So Reed-Sternberg cell lump or lymphadenopathy getting painful when you drink alcohol is Hodgkin's lymphoma, classic. Pathophysiology is that it's a localized single group of lymph nodes affected, and it spreads through contiguous spread. Investigation, so for lymphomas, rule of thumb, you want to do a lymph node biopsy. Makes sense. It's a lymph node, it's a lymphoma, so biopsy the lymph node. So that would be your investigation of choice. And in your lymph node biopsy, you would see Reed-Sternberg cells, which are diagnostic for Hodgkin's lymphoma. You can do other investigations such as CT-PAR, FBC. And FBC can show you high LDH, normocytic anemia. You can do Coombs test. You can do, sorry, that's all. And then histology will show you Reed-Sternberg cells as well. So there you go. So it's like this owl appearance. So if in your exams you see a lymph node biopsy histology and you see like these two owl eyes, like you can see in the middle, those two owl-shaped like eyes are Reed-Sternberg cells. So that's characteristic of Hodgkin's lymphoma. Causes of Hodgkin's lymphoma, EBV, that's a really common cause. So is HIV. And the symptoms, this is usually Hodgkin's lymphoma is painless, asymmetrical, non-tender lymphadenopathy that can become painful if you drink alcohol. You get B symptoms. So you get cervical, axillary, and inguinal lymphadenopathy, alcohol-induced pain, and you can get a mediastinal mass that can compresses your SVC, your superior vena cava, and then causes edema. So these are things that is non-Hodgkin's lymphoma. Staging and arbor staging. And then, so that's also important to remember how it's staged. Prognostic factors is lymphocyte predominant is the best prognosis. If you're lymphocyte depleted, that's the worst prognosis. If you are over 45, that's not good. Stage 4 is not good. B symptoms and a high LDH is not good. So the one that they test the most is what's a prognostic factor of Hodgkin's lymphoma? It's usually high LDH. So if you have a high LDH, that's not good. And then treatment is chemotherapy, vaccinate them because they'll be immunocompromised, irradiated red blood cell transfusions, all of that. But okay, next let's go on to non-Hodgkin's lymphoma. Okay, so there's three types of non-Hodgkin's lymphoma. There's Burkitt's, Waldenstrom's, and diffuse large B-cell lymphoma. Again, each of them have their thing that sets them apart. Just memorize those things so you know which one it is. So pathophysiology, Burkitt's is the proliferation of lymphocytes in lymph nodes and lymph organs. And there's multiple lymph node groups involved, extranodal involvement, non-contiguous spread commonly affects B cells. So Hodgkin's lymphoma is contiguous spread. Non-Hodgkin's lymphoma is non-contiguous spread. And it's the same pathophysiology for all three of them. The Waldenstrom is special because it secretes a special type of paraprotein, a monoclonal IgM paraprotein. So if you see that in the stem, it's more likely to be Waldenstrom. And the way to remember that is W turned upside down is an M. So IgM paraprotein. Yeah, so for Burkitt's, it's caused by CMYC gene, 1814, translocation as well. It's associated with Burkitt's lymphoma and it can be caused by EBV. So that's Burkitt's. For Waldenstrom's, family history, previous chemo, radiotherapy, immunodeficiency, infection, autoimmune, celiac. So all of those ones cause Waldenstrom as well as diffuse large B cell. So Burkitt's is like the one with the unique cause with the CMYC gene and the translocation 814 and the EBV specifically. Epidemiology is that Burkitt's is in young immunosuppressed people. Waldenstrom is in older men, and then diffuse large B cell is the most common type of non-Hodgkin's lymphoma. Yeah, again, the symptoms is common to all of them, the signs and symptoms, in that you can get extra nodal involvement. So extra nodal involvement causing dysphagia, abdominal pain, bone pain, and nerve palsies. And this is key. So in a stem, if you see lymphadenopathy that is painless, rubbery, and symmetrical, it's most likely to be a non-Hodgkin's lymphoma. If you see lymphadenopathy that is painless, rubbery, and asymmetrical, that's more likely to be a Hodgkin's lymphoma. So Hodgkin's is asymmetrical, and non-Hodgkin's is symmetrical. You can also see hepatomegaly, splenomegaly, testicular masses, and some of the main complications that you should remember is the superior vena cava obstruction. So sometimes people present with that or with like edema, spinal cord compression, can also cause visual disturbances and all of that. And those are common to all three of them. And then Burkitt's, it can be endemic in African. There's an endemic form slash the African form, which is the maxillary and mandibular lymph nodes are commonly affected. Whereas the other form is the abdominal lymph nodes. That's a bit niche. I doubt they'll ask you that. Investigation, lymphoma, do a lymph node biopsy. Pretty straightforward. And just remember that you want to also do a full blood count to look at the high LDH because a high LDH is a poor prognostic factor in all of them. For the Waldenstrom specifically, you want to do a monoclonal IgM paraprotein because that's what's so you want to do a bone marrow biopsy to see that because that's what sets it apart from the other two. And then histology is a good way of setting them apart. So Burkitt's lymphoma, you will see a starry sky appearance where the lymphocyte sheets are interspread with macrophages. So usually in the stem, they'll say starry sky appearance on histology, and you'll think it's Burkitt's. In Waldenstrom, you will see Rulu formation. Rulu formation is when the red blood cells start sticking together like this, like in a line or whatever. So they start sticking together. And the sticking together is because of paraprotein. So any disease where there's paraproteins involved, such as in this one, or in myeloma, which also has paraproteins, you will see Rulu formation in histology where the red blood cells are sticking together. Poor prognostic factors, raised LDH, that's the most important one. And I think that's most likely to be tested. Good prognostic factors if it's a low-grade lymphoma, and treatment is chemo and vaccinations. Okay, let's go back. Again, that was very quick. I'm conscious of time, and then obviously you guys can go read about it in depth in your own time. So okay. So our next SBA. A 55-year-old man presents to the heme clinic with a history of widespread lymphadenopathy, fever, night sweat, and weight loss. He has an excisional lymph node biopsy, which with the histology result showing a starry sky appearance. Which of the following is most likely to be associated with this condition? Let's see what people have put down. Okay, someone said EBV. Okay, great. So yeah, so the answer is EBV infection. So this is Burkitt's lymphoma. So this is a well, this is a non-Hodgkin's lymphoma because it's widespread. It's more widespread. It's not as local. So Hodgkin's would be more local. Non-Hodgkin's is widespread. Fevers, night sweat, weight loss. So is this a non-Hodgkin's lymphoma? Starry sky appearance on histology is classical of Burkitt's lymphoma, and Burkitt's lymphoma is commonly caused by EBV infection. Okay, a 61-year-old female patient presents to the GP with a left-sided neck lump. The lump has been enlarging over the last 12 months and is non-tender. She denies any other symptoms. Physical examination reveals bilateral cervical and axillary non-tender lymphadenopathy. There is mild splenomegaly. Excisional lymph node biopsy reveals uniform, densely packed follicles with the loss of nodal or architecture. Which of the following is a poor prognostic marker for the most likely diagnosis? Let's see what people have put down. Okay, so for this one, the answer is raised LDH. So this is bilateral cervical and axillary non-tender lymphadenopathy. So symmetrical bilateral non-tender lymphadenopathy is classical of non-Hodgkin's lymphoma. So this is a non-Hodgkin's lymphoma. Even if you don't understand what the biopsy means, you can just tell by the basis of the type of lymphadenopathy that she has. Densely packed follicles with loss of nodal architecture is a non-Hodgkin's lymphoma. And the poor prognostic marker for any non-Hodgkin's lymphoma is a raised LDH. So that's important. Okay, a 19-year-old man who has just started university presents to his GP after the appearance of a painful tender lump in his neck. On examination, a 2 centimeter rubbery tender lymph node is noted in the right anterior cervical chain. He also described feeling generally unwell with fever and fatigue. There is no evidence of any other lymphadenopathy. Which of the following is the most likely diagnosis? I think this question came up last year in the exam. Couple more seconds. Okay, let's see what people put down. Okay, someone said Hodgkin's lymphoma. Interesting. Yeah, so this question is tricky. So the correct answer is infectious mononucleosis. The reason being is, so I'll tell you why it's not any sort of lymphoma. Lymphomas present with uh, painless lymphadenopathy. This is painful, so it's not your classical painless lymphadenopathy. Lymphomas would also present with B symptoms such as weight loss, fatigue, all of those things. He doesn't have any weight loss. He only has fever and fatigue. And lymphomas could have other types of lymphadenopathy also involved. This is a young man who just started uni, so he's more at risk of developing infectious mono, which is like the kissing virus. And infectious mono classically causes painful, tender lumps in young people who take part in high risk behavior, such as like starting uni, um, and he's got fever and fatigue. So he's not got cancer symptoms, but rather the symptoms of infectious mononucleosis. Hence why this is C and not the other ones, which are all the other ones which are more lymphoma and cancer related. Um, does that make sense? And Richter's transformation happens in CLL, which is old men, and he's not old at all. Um, but yeah, so this is a tricky question, but it did come up last year, so it's important to know this one. Um, Next question. A 71-year-old woman presents to the emergency department with sudden onset severe back pain, which is found to be due to a vertebral fracture. The patient denies trauma or injury to her back. For the past 3 months, she has had persistent pain in her lower back and has felt very fatigued. Her FB sheets show pancytopenia and use and ease show hypercalcemia and poor renal function. What is the most appropriate initial investigation? I think we're on our last topic, guys. I'm so happy. Um, Couple more seconds. Okay, let's see what people have said. Okay, so someone said serum protein electrophoresis, someone said bone marrow biopsy. Valid. I mean, we're talking about heme, so bone marrow biopsy is not, a bad choice. But the correct answer here is serum protein electrophoresis, um, because this is multiple myeloma. Um, Serum protein electrophoresis is the initial investigation in multiple myeloma. The reason why this is myeloma is because well, there's a criteria, there's the Krabbe criteria, one of which is bone. So Krabbe, so B is for bone, so she's got back pain and a fracture. C is for calcium, so hypercalcemia. She's got pancytopenia. She's also got poor renal function, so the R in Krabbe's renal function. So this is classic myeloma. Okay, so myeloma is a hematologic malignancy marked by the proliferation of plasma cells, which occur due to genetic mutations due to the process of B lymphocytes differentiating into mature plasma cells. Just remember, it's a cancer of the plasma cells. Associated conditions is amyloidosis. So search up amyloidosis because it comes up in conjunction with myeloma quite a lot. Epidemiology, it happens in the elderly, Afro-Caribbean, and male population, sorry, and it's the second most common heme cancer. Risk factors are obesity, radiation, carcinogens, and alcohol consumption. Okay. A 6-year-old male is referred to the heme clinic by the GP. The only information received is that the patient was found to have an abnormal ratio of lambda to kappa light chains. What is most likely to be seen on ECG? Okay, let's see what people have put. Okay, lengthen QT interval. Okay, interesting. So it's got something to do with the QT interval. So this is still myeloma because abnormal ratio of lambda to kappa light chains is myeloma. And in myeloma, you get hypercalcemia and you get a shortened QT interval. So hypercalcemia causes shortened QT interval. The way I remember it is that if you have too much C, it cuts the QT interval. That's how I remember it. So yeah. So here's the Krabbe criteria. So the criteria for myeloma is calcium, so hypercalcemia due to osteoclastic bone resorptions. And if you have hypercalcemia, you've got constipation, nausea, anorexia, confusion. And then you've got R for renal, so the light chains deposit in the renal tubule. So because it's a plasma cell problem, the light chain that makes up that plasma cell starts to deposit in the renal tubules. So you get kidney failure, and you can get like proteinuria, or like the GPs will dip their urine and they'll see some sort of problem there, and then they get referred to hospital. And it's associated with amyloidosis, kidney stone, and it can present with dehydration and increased thirst. A is anemia, so bone marrow crowding suppresses erythropoiesis. So because all the plasma cells are differentiating, it suppresses all the other types of cells, so you get anemia. So you get fatigue, pallor. B is for bleeding. You get thrombocytopenia again due to your plasma cells overcrowding the bone marrow, and you can't make platelets, so you can get bleeding and bruising. B is for bones. So because your osteoclasts are overactive, bone your bone becomes more weak and you can get lytic lesions in your bones and you can get pathological fractures and bone pain. So back pain is a very common, vertebral fracture is very common. I is infection. Because you have reduced immunoglobulin production, this increases your infection risk and you get increased susceptibility to infection. Okay, and finally, the way you test it, so you want to do some blood tests to look for full blood count to look for anemia. Peripheral blood film will show Rulu formation. So if you see someone with all the crabby symptoms as well as Rulu formation is myeloma. So Rulu formation is also in Waldenstrom non-Hodgkin's lymphoma, because myeloma and Waldenstrom both have paraproteins as their problem. So you get these sticky red blood cells and Rudu formation. Using these for renal failure and a bone profile to look for how your bones are doing. So hypercalcemia. And then the way to, I think, diagnose myeloma is protein electrophoresis. And you will see a raised monoclonal IgA, IgG in serum. So the most common proliferation immunoglobulin in myeloma is IgA. So remember that it's IgA. And you can also see Burns-Jones protein in the urine. You can do a bone marrow aspiration to confirm diagnosis if the plasma count is severely significantly elevated. You can do imaging, so you would want to do whole body MRI. So back in the day, you could do X-rays, and back in the day, you could see like I think X-ray was first line, but now it's recommended to do a whole body MRI to look for your bones and fractures and bone lesions. And if they have like raindrop skull appearance, in which like there's little holes in their skull, that can also be seen in myeloma. Um, yeah, so there's the diagnostic criteria for myeloma is you either need one major and one minor or three minor um, to get diagnosed. So one major would be plasmacytoma, identified via biopsy, bone marrow having more than 30% plasma cells, M protein elevated in the blood or urine. Minor criteria is your bone marrow showing 10% to 30% plasma cells, M protein slightly elevated levels in blood or urine, and then osteolytic lesions on imaging and hypogammaglobulinemia, so low levels of non-cancerous antibodies. I think for testing, the main thing they could test you on is protein electrophoresis is your investigation of choice. And the thing that you'll see most is IgA. IgA is your most common thing that you'll see. Rule formation in your histology, and just learn the Krabbe criteria and know the symptoms of hypercalcemia, because the way hypercalcemia can present, it can be subtle. So I forgot what the mnemonic is, but it's like stones, bones, groans, something like that. So remember that thing. And yeah, so that's all I have for today. I know it was long. I know that it was a lot of work and a lot to remember, but just keep doing the questions. Heme can be difficult. Don't worry about it, but you all get there in the end. And if you could all just please fill out the feedback form, that would be really, really good. And if you have any questions, please ask me. But yeah, we're done.
Thank you so much.
Thank you.
Thank you so much.
Hey, is it okay if I stop sharing my screen and end the meeting now, or do you still need this slide?